on behalf of Medicine 5 in today's clinical meeting. My presentation is titled "A Stitch in Time Does Not Save 9." So Mr. TR is a 31-year-old pharmaceutical representative from Bangalore. He presented with non-healing ulcers over the left lower limb since 8 months and loss of weight since 8 months. So initially he had a bike injury that happened in April of this year, and then 2 months the ulcer did not heal. He was dressing it daily in a hospital, but after about 2 months when it was not healing, he presented to another hospital and they advised a split thickness skin graft for ulcer cover. So part of the this was in the anterior shin towards the medial side. No, it was not the silencer area, sir. It was the anterior shin. It was on the left leg. So he underwent the split thickness skin graft on 10/8/2024, and 2 weeks after the procedure, he developed a black blister adjacent to the site of the skin graft, and it was discharging a dark fluid and left a painful ulcer. After this first ulcer, in a succession of about 2 weeks, he developed another 8 of these blisters, all of which formed ulcers after discharging some dark fluid. He tried multiple courses of IV antibiotics, oral antibiotics, dressings outside, but the ulcers continued to enlarge and they were very painful. He had a weight loss of about 10 kilos by the time he came to us. This is after 8 months of treatment outside, but his appetite was preserved. He has no history of fever, chronic cough, GI bleed, or altered bowel habits. And he was diagnosed with diabetes mellitus 6 months ago. Index sugars were 260 and he was lean at presentation, but it was well controlled on oral anti-diabetic agents. On examination, he was tachycardic with a regular pulse rate. All peripheral pulses were present. Blood pressures were 160. He was pale and dehydrated with bilateral inguinal lymphadenopathy. No cervical or axillary lymphadenopathy. There was extensive ulceration over the left lower limb with intervening necrotic skin patches and pustules. And there were 3 small ulcers over the right knee as well. The right knee joint was mildly swollen with tenderness of the suprapatellar area, but movements were not painful. This is a photo of what one of them looked like. So he's not had any debridement over this area. Some more. So these yellow things that are there in the intervening skin are actually pustules that are formed near the ulcers. So on general examination, other than a monophonic left infrascapular wheeze, he did not have anything significant on his systemic examination. So in summary, this was a young, otherwise healthy man with a recently diagnosed well-controlled diabetes mellitus with non-healing painful ulcers over his left lower limb which worsened after surgery, and now ulcers over his right lower limb as well with history of significant weight loss. Examination was significant for tachycardia, pallor, extensive ulceration over the left lower limb, and intervening unhealthy skin with pustules, along with few ulcers over the right knee and bilateral inguinal lymphadenopathy. So because he has this complex of ulcers with intervening skin demonstrating pus-filled crusting lesions, this is dermatologically called pyoderma. So differentials that we would consider for pyoderma are infections like atypical mycobacterial infections, nocardiosis, fungal infections like sporotrichosis, chronic ulcerative viral infections, cutaneous malignancies. Medium or small vessel vasculitis can cause skin ulceration. Neutrophilic dermatosis are a big differential. Pyoderma gangrenosum, Behçet's-Sweet syndrome, paraneoplastic manifestations, and venous leg ulcers, but that would not explain this pustular lesions that are there in between the skin. Because he gave history specifically of rapid worsening after surgery, infections and lesions that show the Kibner phenomenon and pathology are to be suspected. So Kibner phenomenon is when if you have some trauma next to the original skin lesion, the same kind of skin lesion develops at the site of trauma. Whereas pathology is when you have a minor trauma over a skin, non-specific pustules or papules occur in that region. So pathology is something that we can induce. On investigations, he had a severe anemia, macrocytic, with a low platelet count, a slightly inverted AG ratio, a high alkaline phosphatase, and a high gamma GT. His HbA1c curiously demonstrated a 26.1% fetal hemoglobin variant. LDH was not very elevated. Pus swab was showing polymicrobial growth of, the polymicrobial growth is for the pus swab. The blood cultures, 3 of them were sterile. Bloodborne virus screen was negative, ANA was negative, dsDNA was normal. Urine routine showed 3+ glucose and protein of 1+, and ultrasound, which we had done in view of this elevated gamma GT with alkaline phosphatase, was showing a mildly coarse liver echo texture with hepatomegaly and no IHBRD. Normal spleen and portal vein. So we went ahead with the skin biopsy. So I've just highlighted the important points here. There is a neutrophilic abscess formation with granulomatous inflammation of the skin that is extending from the epidermis to the dermis. Inflammation extends till deep dermis and the lobules of the subcute. There is no necrosis, no atypical cells. There is nothing suggestive of a medium vessel vasculitis. Special stains that they're done for bacteria, fungal organisms, nocardia, TB, lepra bacilli, all are negative. Pyodoma gangrenosum was a possible differential. So we had already on the biopsy ruled out infections, cutaneous malignancies, autoimmune diseases, and paraneoplastic. Venous leg ulcers were less likely. So the most likely differential that we considered here was pyodoma gangrenosum. So this man had a pyodoma gangrenosum with anemia and elevated alkaline phosphatase and GGT and young onset diabetes mellitus. I'll just say a few things about pyodoma gangrenosum before I come back to him. So it's a autoinflammatory dermatosis characterized by neutrophilic infiltration of the dermis. Usually it goes undiagnosed for a long time, like this man's was, because it actually occurs as a single non-healing ulcer, and then someone does a surgical procedure and it gets much worse. And that is when you suspect pyodoma gangrenosum or other neutrophilic dermatitis. Pathergy is a phenomenon that is seen about in 50% of the people, where they say that trauma causes an exaggerated response of ulceration. They start as pustules, they erode into ulcers, and finally they form a large necrotic central ulcer, and progression occurs between days to weeks. Commonly associated with, many of them are associated with inflammatory bowel disease, about 45%. The next association is with rheumatoid arthritis, and rarely they are also associated with lymphoproliferative disorders, solid organ malignancies as well, and rarely they can occur as paraneoplastic also. This is about in 5% of all pyodoma gangrenosum. So classically they are defined as these violaceous undermined ulcers with an undermined edge with this violaceous rim and purulent base, and finally they become punched out atrophic scars. Now these kind of skin changes are difficult to see on brown skin. They are described on fairer skin. There is no targeted diagnostic test. The biopsy is the biggest identifier, and then you have to exclude other disorders and other differences that might present like this. There are 3 scores that are used, which increase the probability of this being a pyodoma gangrenosum: the Delphi score, Sioux criteria, and Paracelsus score. The management is basically to not do anything surgically, and gentle dressings and immunosuppression. There are varying grades depending on how severe the lesions are. You can go from topical steroids and topical tacrolimus all the way to pulse steroids as well. So back to our patient, his Paracelsus score was calculated to be 14. He definitely had a progressive course. We had excluded reasonably differential diagnoses for the same. There was an irregular ulcer. It was painful. He had pathergy that was demonstrated. He had an undermined wound border and a suppurative inflammation on histology. So even if you exclude this reddish violaceous border, he had a score of 14, and a score of more than 10 indicates a high likelihood of pyodoma gangrenosum. We did a bone marrow as well, which was showing a cellular marrow and myeloid predominance. So right now he's been worked up for conditions that are associated with pyodoma. He's planned for Scopes, PET and MRCP imaging. We have also sent a variant HB analysis. He is receiving analgesia and daily dressings and has been initiated on oral clofazimine and minocycline in consultation with dermatology. Because this man had a high alkaline phosphatase and GGT, and some coarse echo texture of liver, I was just looking up, and there was this 1983 publication in JAMA which said that there was an association of this was a case report of an association of pyodoma gangrenosum with PBC, but I couldn't find any further case reports like this. Thank you.
Thank you, Namrata. Very interesting case. PBC can also be associated with ulcerative colitis, which is both of them connected with pyodermal gangrenosum, but that's very interesting. Any questions?
Yes, the usual suspect. Just one question. What is the anemia? 4.9.
Yeah, sir. So basically, he had been transfused multiple times outside, so we couldn't send like a B12 and iron and all of that. This variant HB was a worry because this HbF percentage was very high. That again can be associated with lymphoproliferative.
Basic things, MCV, retics.
MCV was 103, but B12 was 2000. Suspect, I mean, he could have been. He's received like 4 transfusions outside and 2 here. Retics is corrected reticulocyte count is 1.8.
What was Einstein's in marrow?
Einstein's in marrow was normal by staining. We have to look for a loss. We have to look for a GI loss also, and but he doesn't historically give any symptoms of GI loss.
The other thing always to look at is
the manual platelet was also low.
So his mean platelet volume was low only. Manual platelet was about 50, 60. Why the low platelet? Bone marrow is normal. At that time, he had some fever when he presented. But he doesn't have schistocytes, so DCT is negative. LDH is 236.
Second thing is always look at the protein albumin. If you have low protein, low albumin, most likely there's a gut loss, and you already have an MCV that is high. Most likely terminal ileum is involved. So if the gut is involved in that sense, either it's ulcerative colitis with a backlash ileitis, or it's Crohn's that could be involving. So in any patients we are suspecting a gut which could explain the peripheral manifestation, those will be some cues that you can look up. Finally, it will be the scopy with biopsies that will tell you the answer. But these are some of the cues which you can take lead in. Okay, if there's no further.
He's received 3 here, so he was under surgery initially. So he's received 3 in surgery, and he's received about 3-4 outside also over these 8 months.
Maybe losing Thank you, Namrata. We'll move on to the next presentation. Double Trouble by Dr. Kezia and Philip from Medicine 3.